Hi everyone, thank you for joining the show. I'm El-Khoury, and today it is my pleasure to welcome Dr. Eugenio Zabaleta, who was a clinical chemist at Ohio Health in Mansfield, Ohio, and also was a professor in the School of Nursing in Mansfield, Ohio, which is very relevant to the discussion we're having today on working successfully with nursing. Eugenio, welcome, and thank you for joining us.
Thank you for having me here.
Absolutely. So first, would you mind starting by describing to our audience what is your role as a clinical chemist at your institution?
So that is a little funny because I work basically as a bridge between how the test is utilizing in the clinical setting, that is the clinical performance of the test, and how we do in the and how we do it in the lab, which means the analytical performance, right? And I am always going between the physician and nurses to so the clinician to the laboratory. So if you see it from the point of view of the physician, they think that I am a spy, and if you see it from the point of view of the laboratory, I am a traitor. So nobody likes me, but we can achieve.
I'm sure that's not true.
We can achieve very good results when we work collaboratively between the two areas.
So in your work working with these two very different groups in the hospital setting, you're basically providing your expertise from the laboratory side to the physician and nursing group, our clinical teams. What have you learned about major differences, especially when it comes to the culture of nursing versus the culture of laboratory, that helps us in working together and enabling you to work successfully with them?
We are completely two different worlds that don't even speak almost the same language. For example, there are three things that I will mention. The first one is they are driven by policies. Policies tells them what to do, know how to do it. So they have a very deal of degree on how they perform that task. In laboratory medicine, we have mainly SOPs that are how to do papers. We need to do everything by certain way, and there are no deviation because everybody has to be able to follow the process and take over for the other person. So that make us very structured, and they more like free to have the patient care and develop their own practice of medicine. So those are completely two different things. The other big, and sometimes when I talk to them, I try to explain that the laboratory is very structured for that, and we have SOPs for everything, right? Everything that we do in the lab, we have SOPs. The only SOP that we don't have yet is how to go to the bathroom, and probably is because the competency assessment will be a kind
difficult.
Of awkward. So sorry for the joke, but anyway, so the other very important part is every patient knows who they are and what they do, and they are the most recognized profession. There are survey every year, and they have won since its conception in 1999, except for 1 year that, of course, it was when September 11 happened, that it was firefighters that won that year. But basically, that is the other thing. And the third one difference is the change in their profession is more dynamic because they are regulated and licensed by state boards, and laboratory medicine is regulated by a law from Congress. Yeah. And if you know how fast and dynamic Congress is, you can identify that our practice doesn't change that much from the regulatory standpoint. So
absolutely, CLIA hasn't been updated since 1988, and so definitely some updates are needed on the laboratory side. So I appreciate those perspectives, and I'm curious if you can share one successful story of your laboratory working with nursing to accomplish that goal.
So there was one project that we did in 2011. And when I tackled this project, it was the utilization of Clostridium difficile testing. And at that moment, there were a new recently published guideline that changed how we should be doing testing, what tests we should be, and I will not give a lot of details, but that project covered from ordering tests that we created in the computerized physician order entry, aka CPOE, an algorithm that was very intuitive for the nurses. Also, we teach them what sample is appropriate according that it was all recorded according the clinical indication for that test, and send them to the lab, the testing that the lab will perform, the result, and also it went even beyond the nurses and the physician to the social worker when they were doing the disposition of the patient and avoiding, because at that time nursing home required 3 negative test results because the toxin at that moment, one of the prevalent testing, it was not recommended and sensitive enough, and they wanted a patient to be tested 3 different days. So we were keeping all of these patients for a long period of time just to prove that they were not having an active infection. And that was not recommended anymore. So on all of that, it resulted in the length of stay of our patients went from 12.9 days to 8.5, and that cut in length of stay was resulted in different things. First, we were collecting much less sample, and the nurses loved me for that, and also the lab loved me for that. So that is the good side of the story that I said before.
Because to clarify, we're talking stool samples, right?
Yeah,
exactly.
Stool samples. So the joke was that between nursing and the laboratory is that when nursing and laboratory work together, there are less crap for everybody. So the techs were happy, the nurses were happy. We were giving the information sooner. We were detecting Clostridium difficile infection sooner, and that resulted, and I will not give you all of the different outcome measures that we put, but one of the biggest one is that we reduced the cost of the hospital by almost 10,000 per patient. When you multiply that for the whole patients in that year, it was $1.1 million. And that was my first cost-saving project of $1 million cost saving. And so I remember that project very,
that's awesome.
very vivid.
That's awesome. So from that experience, what if you were to give people on the laboratory side who are trying to work with nursing or even physicians advice in terms of taking these projects on and collaborating, what recommendations would you share from your own experience that would be helpful to them?
First of all, you have to understand what are your resources. What is the expertise in your hospital? Because you will be able to find what other people does, and you want to mimic exactly that, but you don't have the same resources. So don't let perfection be against good. So what you have to do is just try to adapt the project to and scale back to what your institution characteristics are, the patient you serve, and don't try to mimic exactly what other people does if you don't have the same resources. So it's important to try to get a compromise with the teamwork with the team that you are working, and create that positive teamwork, but don't create frustration, because you will be shutting you down on possibilities of having other projects go ahead. So be Be very conscious about your own resources. Don't shoot for the moon. Be realistic.
That is wise advice that I would have appreciated 10 years ago. So, Dr. Eugenio Zabaleta, thank you so much for joining us today. Thank you all for watching.
Thanks.